Okay, well, let's get going. So this is all about menopause and heart health. And I wrote what every woman needs to know, but I thought, frankly, every person, every human being needs to know this because menopause affects everybody. So, yeah, I'm really excited to move forward with it. So, I just wanted to share a little bit about me so you know who I am, why I'm bringing this to you. Menopause and perimenopause are really passions of mine, and it's really all I do professionally in practice. But as you're going to learn today, menopause affects every part of your body, every part of your mind. And I'm saying your for the female identifying people in the room, but if others are listening, you're also welcome. But I'll probably very often be saying your. Um, I'm going to especially highlight how menopause can affect cardiovascular health because a lot of us have learned that cardiovascular disease is the number one killer of women. And I want you to know how menopause can impact you and what you can do about it. And it's really my hope that at the end of this talk, you're going to learn at least one thing that inspires you or empowers you and ultimately improves your quality of life. Because when women are resourced and healthy, the world is always a better place. I have to just give a little disclaimer because I have a medical license that this content and this discussion are really for informational purposes only. No doctor-patient relationship is formed, even if I am your doctor in real life. And information provided here does not constitute medical advice. You should always discuss your personal medical concerns with your practitioner, please. So let's get going. I thought it would be fun to structure this as sort of a myths and misconceptions versus facts kind of experience. Um, and this is one that I hear a lot and it kind of drives me crazy. Menopause just means that she can't have children any longer, and perimenopause is just a buzzword. And first of all, I think women are much more than their reproductive potential. And as you're going to see, there is so much more going on than periods simply stopping and fertility ceasing. So let's talk about the menopause transition. Some definitions. Perimenopause is simply the time prior to when your period stops, when your hormones are becoming much more erratic. This is when your symptoms are generally most severe. Perimenopause usually happens in a woman's 40s, but it can start as early as the mid to late 30s. It can last up to 10 years with an average of about 4 to 8 years. And symptoms are most severe in that later part of perimenopause, right before periods stop. Menopause is the complete absence of a menstrual cycle for 1 year, meaning you have not had a period for 365 consecutive days. They're early and late stages with different symptoms. And really, menopause is just 1 day. And everything after that 1 day is technically postmenopause. The average age of menopause is 52, but I'll tell you, there is a lot of variability. Some women could be in their late 40s, some women are in their late 50s. And a woman can spend up to half her life in postmenopause. Hot flashes and the other symptoms of menopause, they don't necessarily stop just because your periods have stopped. Those can last far longer. So 10 years, longer than 10 years in some cases. And we often call this time frame when your symptoms are at their worst, we call this the menopausal transition because you could be bleeding or not. A menstrual period is not really terribly relevant in terms of your symptoms. And your estrogen doesn't just fall off a cliff. Unless you've had your ovaries removed, or if you've had chemo or radiation to your pelvis that pretty abruptly put you into early menopause. And I've seen some charts that just show this like beautiful, graceful decline of hormones, and that's just generally not accurate. So if you kind of just like zoom in here to estrogen and progesterone, estrogen in yellow, you'll see these erratic spikes and dips. And in the premenopausal years or your reproductive years, there's this beautiful balance, right? Where estrogen and progesterone, they are just well balanced. They support each other. Everything's working well. But in perimenopause, you might get these excessive surges of estrogen in yellow, coupled with lower levels of progesterone, which are in pink, and with just lots of spikes and dips. And estrogen can spike really high in perimenopause relative to progesterone and then crash back down. That's when we often see a lot of the symptoms, especially hot flashes. High estrogen relative to progesterone can really cause a lot of heavy bleeding, which can be super confusing if you're like in your 40s and all of a sudden you're having heavy bleeding. And another time when this situation is happening is in puberty. So you could even think about perimenopause as reverse puberty, really. And overall, yes, estrogen is going down, but typically over the course of years, and until it does, it's frequently high relative to progesterone. Progesterone typically drops before estrogen does. And I'm saying typically because every woman's experience is different. These are just some known patterns. So some women will just wake up one day and then never have a period again and have no symptoms, and that's amazing. But many women have different experiences. These are just typical patterns. Eventually, estrogen will stay low throughout menopause, and then those fluctuations will no longer bother you. But until then, I kind of call it the storm before the calm. And I overlaid, I added testosterone to this image because we'll talk about testosterone later, but it really peaks in your 20s and then it does a more just like steady decline until it levels out in about your 70s. So, you'll see that through your reproductive years, estrogen and progesterone, might be pretty level until perimenopause, whereas testosterone can drop long before that and can just continue until menopause. But we'll talk about testosterone. So how do you get a diagnosis of perimenopause or menopause? Perimenopause is a clinical diagnosis. There's no one single test for it. And doctors basically just diagnose you on your symptoms. I'm pretty suspicious of perimenopause if I've got a 35-year-old or older patient and she's got any of the symptoms of the transition. While there's no single blood test, you can do a few tests. Follicular stimulating hormone, you may have heard of, it's called FSH. It stimulates the follicles to develop. In late perimenopause, it can be more elevated. And single readings are really not that helpful in perimenopause to predict the time to menopause because it can fluctuate, but it can be one piece of the puzzle. Anti-Müllerian hormone, or AMH, can be low as you approach menopause. It's made by the follicles. It's reflecting ovarian reserve. And it might reflect time to menopause, but we rarely really order it unless a woman is trying to conceive. And then estradiol is another test that we can run in perimenopause, but it could be high if we happen to be catching a spike, or it could be low if we happen to be catching a dip. So it's got these wild fluctuations, meaning it's rarely that helpful, but we can order estradiol and kind of try and get a read on what's going on for you. Really, what we ought to be doing in perimenopause is ruling out other causes. So your physician or your practitioner should test you for some other conditions or just evaluate you for other conditions because other things might mimic perimenopause. This might mean thyroid testing. This might mean a CBC. It might mean, some nutrient testing like iron, B12, or folate. And I've just personally seen both thyroid disease and anemia create these sort of perimenopause-like symptoms that resolved when we treated the actual problem. So it is important to see a practitioner and make sure that that's really what's going on. And if the other tests are normal, then she's probably in perimenopause, which is very real and very treatable. And then menopause is also a clinical diagnosis. And basically, if you're in the right age range and you're 1 year without a period, barring other conditions, then we diagnose you with menopause. The average age, again, is 52, but you can be as young as 45. And if younger than 45, it really does warrant further workup to make sure nothing else is going on. During this time, that AMH test will be low, estradiol will be low, and then FSH will be high, usually over 25, but they're really not necessary because we can just do a clinical diagnosis. But this is the time for a wellness check. Even without symptoms, menopause is a time of extraordinary changes in a woman's health. It's really important to see your physician and get a comprehensive checkup. That means checking your cardiovascular risk markers like your blood pressure. It means getting a lipid panel to know, what your cholesterol numbers are like. I usually also check apolipoprotein B to check for additional cardiovascular risk. This might mean a thyroid screen, a CBC. This is checking on your blood sugar and your A1C to make sure we don't have some insulin resistance or prediabetes in the works. And this might also mean some nutrient deficiencies like iron or B12 or anything else that just comes up in a visit. So, even if you're not having any symptoms and if things are going great, I really encourage women to be seen by their practitioner to make sure that everything is as it should be during this time. This is my least favorite of the myths, but it's just hot flashes. No. So the fluctuation of hormones in perimenopause and menopause affects a woman's entire body. Nearly every organ in your body has receptors for estrogen, progesterone, and testosterone, which we collectively call your sex hormones. Because of that, there are many diverse symptoms of the menopausal transition. Yes, hot flashes and night sweats, but also insomnia, breast tenderness and pain, urinary incontinence, vaginal dryness, joint pain, frozen shoulder is very common, acne, constipation, gas, and bloating, dry skin and itching everywhere, your ears, just everywhere, hair loss, difficulty with word finding, forgetfulness, nerve tingling, headaches and migraines, weight redistribution going from maybe a pear to an apple shape, heart palpitations, very common. And mood symptoms are very common. Irritability, depression, rage, rage is common, anxiety, panic attacks. And my favorite of the symptoms, the one I hear the most often is, I just don't feel like myself. And I can tell you very often women experience one or more of those symptoms before they ever have a hot flash. So if you're not having hot flashes and you just don't feel like yourself, please know that that could be, it could be part of this menopausal transition, and you should definitely see your practitioner. Oh, and hot flashes are a minor inconvenience, and you can just power through them. This is my second least favorite myth. So this slide is very wordy, and this is so you can take a photo of it and take it to your physician if they argue with you and tell you that you should power through your hot flashes. So let's talk about hot flashes. Do you think you should just suffer through them? Over 80% of women have them. Research actually shows that hot flashes can be an early warning sign of cardiovascular trouble and not just a quality of life issue. Your body is not trying to sabotage your workday or your sleep by giving you hot flashes. Your body has an innate wisdom, and most symptoms are signs of larger problems that we just need to listen to. So if your doctor has ever dismissed you or your hot flashes by saying that they won't last long or, tough it up or whatever, please just show them this and tell them to read the papers I've referenced here because they aren't nothing. They are linked to cardiovascular risk, especially when they are very frequent or severe. Hot flashes are associated with a higher blood pressure, arterial stiffness, and subclinical atherosclerosis. So, like before we're even seeing maybe changes to your lipids, they can cause surges in sympathetic activity and blood pressure spikes. And women with persistent hot flashes show more markers of small vessel cerebrovascular injury. So it's not just hot flashes, but the hot flashes do matter. Menopause only affects women in their 50s. I think we just like established that the transition can affect women as young as in their 30s, but there's more. There are 1 billion people experiencing perimenopause and menopause worldwide. And not everyone born with ovaries will have children, but they will all go through menopause if they live long enough. And yet, this shame and secrecy around menopause, as well as just a lack of accurate information and support from the medical community, has made the process of getting good care really difficult. But say you aren't even a person with ovaries experiencing menopause, 20% of the American workforce is. And this is when women are at the height of their careers, when they need the care the most so that they can do all the demands of their busy lives. But really, everyone is affected. The men, these men in the office, are potentially partnered with women who are going through menopause, and you can bet they're affected. The people who are doing it, who are going through menopause, probably have children experiencing puberty while mom's going through this transition, which is an exciting time for everybody. So, frankly, really, everyone on the planet is impacted by menopause. And OB/GYNs are well equipped for menopause care. And this makes sense. I love obstetricians and gynecologists. I refer to them all the time. And this makes sense, right? Like they take care of babies, uteruses, cancer. We sort of make some assumptions that gynecologists are the ones we need to go to for our care when it comes to menopause or any female-related concern. There was a recent study that just showed that yes, gynecologists are more likely to prescribe hormone therapy to women in menopause. However, most women still don't receive care for their symptoms. So this is actually just a very recent paper presented at the just this recent October 2025 Menopause Society annual meeting. 5,500 women with menopausal symptoms were studied, and about 64% were seen by gynecologists, 17% by internal medicine, 12% by family medicine, and 5% by endocrinology. But only 17% received treatment for their menopause symptoms, including the 64% that were seen by gynecologists, which means most of them did not get any treatment. Of the ones that did get treatment, only 34% were offered or received systemic hormone therapy for their hot flashes. 47% received vaginal low-dose estradiol, and 16% received an SSRI prescription. So gynecologists were more likely to give systemic estrogen. Family medicine internists were more likely to give SSRIs. But midwives and nurse practitioners were actually more likely to prescribe hormone therapy than physicians. So a shout out to the nurse practitioners and midwives. And if you've had trouble getting good care, please know that it's not just you. A 2019 Mayo Clinic study showed that less than 7% of medical residents felt prepared to support a menopausal woman's needs. And it did include gynecology residents. So this is a systemic issue. Medical schools haven't been teaching about menopause. Those of us who know enough to be good at treating it had to seek that training out for ourselves after graduating. And frankly, OB/GYNs are in limited supply. They've got a lot to do. They're taking care of all the pregnant people, all the gynecological cancers, and they really don't receive that much training in menopause. So, we need more people in this field who can take care of midlife women's needs. So you need to know what's going on for yourself and how to identify your symptoms so that you can advocate for yourself and get good care. I really recommend just talking to your friends and getting recommendations. Hey, who have you seen that's been helpful? And then menopause.org is a really great resource where you can find a practitioner who specializes in midlife women's care. Now, I kind of want to pivot to sort of some hormone therapy sort of misconceptions and maybe answer some questions some of you might have about hormones. And this is kind of sort of the elephant in the room. Estrogen causes breast cancer. This concern came from the 2002 press conference, which was held by the lead researchers of the Women's Health Initiative, the WHI study, which was published in 2002, and it involved over 27,000 American women. The goal of the study was to study the prevention of cardiovascular disease, breast cancer, and osteoporosis in postmenopausal women. So they were studying prevention. Prior to the study, millions of American women were on hormone therapy for menopause. It was the fifth most prescribed medication in 1975, the synthetic version of it, with most studies showing benefits, but there was no randomized control trial. It had 4 arms. There was an estrogen arm for women who had had a hysterectomy, so they no longer had a uterus, so estrogen only. There was an arm for estrogen and progestin for women with a uterus, and then there was a placebo for both groups. The study had several problems. For one, the average age of the participants was 63, meaning plenty of these women were well into their 70s, which is older than we typically start hormone therapy. The majority of the subjects had an increased risk of cardiovascular disease already, and some already had established cardiovascular disease and were on treatment, making it sort of unsuitable to study cardiovascular disease prevention. And then the estrogen that they used was conjugated equine estrogen, which is synthetic. It's Premarin, which is short for pregnant mare urine. And then the progestin was medroxyprogesterone acetate, or MPA, which is a synthetic progestin that we don't really use any longer. We did get a lot of great information from the WHI, but unfortunately, the lead researchers announced to the media with great fanfare and drama that estrogen causes breast cancer and strokes and dementia. And it went as viral as it could in the age before social media. The study was not even published yet, so doctors and researchers couldn't read it. And it essentially just terrified every physician and patient into stopping hormone therapy because the media really went nuts and we were all scared. So what did it actually report if you actually read the study? Well, 20 years later, the researchers have rescinded all of the statements that they made at that press conference because when the data was properly analyzed, they found estrogen to be protective from breast cancer, not dangerous. This is a free study. You can download it. You can read it for yourself. This is the revised update from the Women's Health Initiative in 2020. It's a free article in the journal JAMA. And it actually showed a significant decrease in breast cancer in the estrogen-only arm. The problem, it appears, was in the synthetic progestin, the medroxyprogesterone acetate. We no longer use MPA because we have far safer alternatives, including progesterone, which is quote unquote bioidentical. It's exactly what your body makes. We can actually just give progesterone. Most of us don't use conjugated equine estrogen anymore, even though it is still available, because we prefer to prescribe 17-beta estradiol, which is bioidentical. It's chemically the same as what your body actually produces. And it's available in a variety of forms: a patch, a ring, a cream, a gel, a mist, a pill, name it. You can get it in any form. But even for this study, even the arm that got the terrible progestin, there was no difference in breast cancer mortality. meaning even in this more dangerous combination of medications, while there was a higher risk of actually detecting breast cancer, there was no higher risk in death from breast cancer. So since then, there have been several studies that have confirmed the safety of 17-beta estradiol, especially when given transdermally, and especially with oral micronized progesterone. And to that end, in 2002, when the press conference just went viral, the FDA pretty quickly slapped a black box warning on every estradiol product warning women of breast cancer, stroke, and probable dementia. And after about 10 years of petitioning by doctors, researchers, and patients, they've finally decided just 2 weeks ago to take it off. So the packaging will still include some cautions, but it won't have the black box warning, which is the highest level of warning we have. And it signifies life-threatening risk. So it's inappropriate to have it on these products. Now, is menopausal hormone therapy right for you and everyone? No, it's not right for everyone, but we shouldn't use fear to make those decisions. We should use science and logical decision making. This is a very common question I get. You know, my family member had breast cancer, so I can't take hormones. My mom, my sister, my aunt, my grandmother, etc. And I can see like there's a lot of fear there, right? It makes sense that women would be concerned about this. But family history is really important, but it's not the critical deciding factor for whether or not a woman is a candidate for menopausal hormone therapy. So this is the 2022 hormone therapy position statement of formerly known as the North American Menopause Society. Now they are the Menopause Society. And they have discovered, or they have reported, that observational evidence suggests that hormone therapy use does not further increase the relative risk of breast cancer in women with a family history of breast cancer, in women after having their ovaries removed for BRCA1 or 2 variants, or in women who have had a benign breast biopsy, meaning I had a lump, I got an ultrasound, they did a biopsy, and it was negative. That is not a contraindication. So even if your family member had a BRCA variation, you may still be a candidate. Even if you yourself have a BRCA variation and you have been treated, you may still be a candidate. And even if you've had breast cancer, this should still be your decision. There are several observational studies in women with a history of breast cancer that show a decreased risk of recurrence or a neutral effect after taking estrogen therapy. This is again from that same paper. Women in consultation with their oncologist may choose hormone therapy after being fully informed about the risks and benefits. Several observational studies in women with a history of breast cancer have shown decreased risk of recurrence. So bottom line, please talk with a knowledgeable practitioner, download this paper, take it to your doctor, and have a fact-based and goal-based discussion. Additionally, there are just many, many options for women who are not candidates for systemic hormone therapy, and just nobody needs to suffer. So, you know, advocate for yourself if you're in that camp. Now we are the American Heart Association. And this was a big fear that came out from that press conference. Hormone therapy causes heart attacks and strokes. The fact is, not all hormone formulations are the same. And I know this is a lot of words, but transdermal 17-beta estradiol, which is bioidentical, which is what we typically prescribe, is quite safe and may even be protective. The Women's Health Initiative used conjugated equine estrogen, which is Premarin, which has been implicated in more inflammation and a higher risk for clotting. So the warnings about hormone therapy causing strokes and heart attacks was pulled from the Women's Health Initiative, but we're not using those products now. And then it was very likely the medroxyprogesterone acetate, that synthetic progestin, that actually was a significant culprit for the stroke and MI risk. So we can't apply those apples to these oranges, the apples of this one study to the oranges of what we actually prescribe today. And these days, most clinicians just prefer to prescribe the 17 beta estradiol with the oral micronized progesterone because they are so safe, even for women with pre-existing cardiovascular disease. So, the route matters. Transdermal versus oral estrogen actually can make a difference. Transdermal estrogen does not increase the risk of MI or stroke, even if they've already had an MI or stroke. It has a lower thrombotic and stroke risk. It can potentially reduce the incidence of myocardial infarction, and it significantly reduces the incidence of diabetes, which is a major risk factor for MI. Oral micronized progesterone has minimal effects on any of your lipids or blood pressure or coagulation markers. It can actually preserve endothelial function and nitric oxide bioavailability, and it does not increase venous thromboembolism, stroke, or MI risk, even if your baseline risk is already elevated. And if you need to argue that point with your doctor, take a picture because these are the references. And, I will email these to me if you reach out. So I want you to have all the information. Okay, testosterone has gotten so much press, and I don't know if any of you saw the New York Times had a big cover story all about testosterone therapy. And this is a question I've heard before, but isn't it only for men with erectile dysfunction and jacked up bodybuilders? Um, no, and the testosterone those individuals are taking, especially the jacked up bodybuilders, is not what we are giving to women. The fact is, women make up to 10 times more testosterone than estrogen. They just make less than men. So I will say that again. A female body with ovaries makes 10 times more testosterone than estrogen. Men also make estrogen. It's just that they make less than women. So why are we calling them sex hormones when everyone makes them? I don't know. I didn't come up with that term. But you have receptors for testosterone in nearly every organ and tissue type in your body, including your brain, including your bones, including your heart. So let's talk about testosterone. This has gotten very little attention until recently, and then it sort of exploded. And it's just usually not something that physicians who are working in a sort of a major hospital group will usually test. But here's what we do know. It is crucial for muscle growth and maintenance, which keeps you from becoming frail in old age. There are receptors for testosterone in your bones, and we know that when men have low testosterone, that's when their susceptibility to osteoporosis actually increases. It's very important for the collagen matrix and skin quality. It's important for your libido and even the ability to achieve orgasm. And because it does cross the blood-brain barrier, it can impact your mood and your motivation, which is how it affects your libido, is because it's working on your brain. Low testosterone can cause or contribute to depression, anxiety, low motivation, exhaustion with normal activity, weakness, sagging skin. And the kind of the key phrase that I hear that makes me think of testosterone is, I feel emotionally flat, which looks a lot like depression. So talk to your doctor if you think this might be playing a role for you. Symptoms can mimic a lot of other conditions like iron deficiency and low estrogen and hypothyroid. So please don't self-diagnose. Please get it checked out. And you should know that it is very safe. Women receive 1/10 of the male dose. So women don't get weekly injections of testosterone. They get 1/10 of the male dose. And when prescribed appropriately, it has little to no side effects. There is no FDA approved product. So we usually prescribe it to compounding pharmacies as a cream or a dissolving tablet or troche. So there are options. And my rebuttal to some people who say there's no safety data in women. First of all, we give women drugs all the time that we've never studied in women, only men. Women actually make this hormone, so why would we treat this any differently? And two, we have mountains of safety data actually in women who are transitioning to men, taking much higher doses and not dying from it. So it's actually quite safe. And no, I promise you will not look like a bodybuilder. We have to give you way more than that. This is very common. I have to stop taking hormones 10 years after menopause or as soon as possible. I met a woman at a recent event who said, "Why, I heard I have to stop taking it like really soon after menopause." And that's old information. Again, back to the 2022 hormone therapy position statement for the Menopause Society, there's no general rule for when you need to stop it. If the benefits of continuing, which would be prevention of osteoporosis, dementia, cardiovascular disease, fending off hot flashes, night sweats, etc., if those benefits outweigh the risks of continuing, there's no reason to arbitrarily discontinue. And many women have hot flashes for many, many years, long into menopause. And why should they have to suffer? If you needed glasses because your eyes are failing you in old age, you would wear glasses, right? So why are we telling you, okay, you're too old now, we're going to take away your glasses? There's no reason to arbitrarily stop a woman's hormones. This should be a decision that you make in concert with your physician or your practitioner, which is really the gist of this whole talk is talk to your doctor and make a decision with them. So that is it. And I will tell you that this talk was so much bigger and I had to narrow it way down because menopause is a massive topic that I could talk to you about all day. I hope you got something from it. And if there are questions that I didn't cover, please feel free to ask. I want to leave you with some recommended reading. Take a picture of this, write them down. My top two favorite books to kind of answer your questions about menopause are Estrogen Matters, which is a really excellent deep dive by a physician and a journalist into sort of the misconception around estrogen. And then the newly released The Menopause Moment by Kelly Casperson. She's actually local to Bellingham. So it's a fantastic book. She's hilarious.